valvular heart disease guidelines. And these were really an update that those of us working in the US have been waiting for a really long time, because the previous guidelines were outdated. They did not include a lot of the transcatheter therapies. And many of us felt that the ACC guidelines were far behind the European guidelines, because the European guidelines seem to be updated on an almost 2-yearly basis, especially for valvular disease, where there's been such growth in the clinical literature and the clinical data. And so the US guidelines still didn't have anything about intermediate risk, forget about low risk, but they had stopped still. TAVR hadn't really entered into the guidelines. So we really did need this guideline change. Now, I'm not going to spend a lot of time going through a lot of the guidelines, spend a lot of time going through diagnoses and what is needed to diagnose valvular disease, what tests are needed. And they also spend a lot of time on follow-up of patients with valvular disease. Okay, I'm just going to go through some of the highlights until Dr. Prendergast joins, particularly what I, as someone treating patients with valvular disease with transcatheter therapies, found interesting. So the first part, let's talk about aortic. They start with, one of the big updates is really, they really clarify, which I think was needed, the different stages of aortic stenosis. Okay, so you see here they start with calling stage A, a patient who's at risk of AS. So no symptoms, does not have severe AS right now, but has a bicuspid valve or has aortic valve sclerosis, a velocity less than 2 with normal leaflet motion. Then they have stage B, progressive aortic stenosis. So this is someone with mild to moderate leaflet calcification, fibrosis of a bicuspid or trileaflet valve with some reduction in systolic motion, and all rheumatic valve changes with commissural fusion. So now the velocity starts increasing from 2 to 2.9. It's called mild AS if the velocity is 2 to 2.9 and a gradient less than 20. Moderate AS is defined as a gradient from 20 to 39 and or a velocity of 3 to 3.9 meters per second. These patients usually have no symptoms, have a normal ejection fraction, and have early LV diastolic dysfunction, which may be present. Now, I say they may have no symptoms, but we do know that if this moderate AS is associated with other valve disease, coronary disease, or even depressed ejection fraction, then that may change and there may be some symptoms. Then they go into class C, and class C are patients with asymptomatic severe AS, and they divide it into class C1 and C2. C1 is sort of the more typical patient we would call asymptomatic. So it's someone who the valve has severe leaflet calcification or fibrosis with severely reduced leaflet opening. By our definitions of hemodynamics, the valve is, the stenosis is severe, so the max velocity is greater than 4. The mean gradient is greater than 40. The aortic valve area is less than 1, or the indexed aortic valve area is less than 0.6, but that's not required to define severe AS. And then there's very severe AS, which is a velocity greater than 5 and a mean gradient greater than 60. These patients may have diastolic dysfunction, LV hypertrophy, but normally have a normal ejection fraction. They have no symptoms, but you may want to do exercise testing to confirm their symptom status. And there's currently a study called Early TAVR, which is looking specifically at these patients. One come join me. Dr. Bernard's a little bit late, so we're just briefly looking at the European guidelines the US guidelines until he arrives, and then we'll look at the European guidelines. And then there's C2, which is asymptomatic severe AS with LV systolic dysfunction. So all the same hemodynamics as severe AS, but now an ejection fraction less than 50%. Then they go into stage D, which is kind of the typical patients most of us see, okay, and the ones that are being sent for surgical aortic valve replacement or TAVR. So here it's a patient who's symptomatic with severe high gradient AS. They got severe leafy calcification and fibrosis. The hemodynamics is, as we mentioned before, velocity more than 4, gradient greater than 40, and a valve area typically less than 1. They now can have all the consequences of severe AS, such as diastolic dysfunction, hypertrophy, and pulmonary hypertension. And they have the typical symptoms of AS, such as exertional dyspnea, decreased effort tolerance, heart failure, angina, syncope or pre-syncope. They also clarify then the patients with symptomatic, severe, low flow, low gradient AS with reduced ejection fraction. Okay, so this is the patient with a depressed ejection fraction less than 50, who we think has severe AS. Their valve area is less than 1, the resting velocity less than 4, and the mean gradient is less than 40. They do suggest that you can do a dobutamine stress echo. It may confirm for you that the valve area is less than 1 and a Vmax greater than 4. But in clinical practice, we don't always do dobutamine stress echoes on these patients, particularly because we've shown, I think, particularly with the TAVR data, that even the lack of contractile reserve does not exclude benefit from treating the patients with low flow, low gradient AS. They can have all the same consequences and symptoms as D1. And then they also clarify D3, which are the patients who are symptomatic. They have severe low gradient AS with a normal ejection fraction, or what's called paradoxical low flow severe AS. So yeah, these are the patients usually with preserved ejection fractions, with a small left ventricle, with low stroke volume, increased wall thickness, and restrictive diastolic filling, who have a valve area less than 1, index less than 0.6, with a velocity less than 4, and pressure less than 40. So very similar to D2, but the difference is the ejection fraction here is normal. But to make this diagnosis, you also need stroke volume. So you have to have a stroke volume index less than 35, which is measured when the patient is normotensive. So this is really important. We sometimes have these patients and we cath them and do invasive hemodynamics, and they're super hypertensive at the time you're doing it, and you really will try and drop their blood pressures before doing the hemodynamics. So I thought this was a really clear classification of the different stages of AS that they had in the new guidelines. So they give also what the recommendations overall are for aortic valve replacement. The class 1 recommendations, so the D1 patients with severe high gradient AS and symptoms by history or exercise testing. Asymptomatic patients with severe high gradient AS and ejection fraction less than 50. So that was the stage C2. The stage D2, symptomatic patients with low flow, low gradient AS, and then symptomatic patients with paradoxical AS, if you can be sure that the AS is the most likely cause of symptoms and you found no other cause. So this, I apologize, this diagram is a little bit hard to read. Let me just see if I have a better one, but I'll try and go through it here for you. So here it talks about, this is your patient with AS, an adult patient with AS, the first thing you do is you perform your risk assessment, right? If the patient is high risk or prohibitive risk, so they have a high STS score, they have frailty, they have multiple organ systems involved, but they have a decent life expectancy, a good life expectancy, okay, then these are clearly TAVI candidates or TAVR candidates, right? If they have the anatomy that's suitable. If they have a short life expectancy, then they talk about palliative care if their life expectancy is less than 1 year, okay? In the patients who are not high risk, okay, they then break it down really into a couple of questions. And the main one is really related to patient age. And this is the first time we've seen the guideline where the treatment of valvular heart disease is not based on surgical risk, but it's based on age, all right? And so they break it down into 4 groups. If you have a patient who's less than 50, okay, then you should really be trying to do in that patient a mechanical aortic valve replacement. If they're 50 to 65, it could be mechanical or bioprosthetic, but essentially trying again to be mechanical. And yeah, for biological valve, a class 1 indication for surgical AVR. And then they break it into these two other groups here, the patients who cannot take vitamin K antagonists and the patients who are 65 years, older than 65. And let's just look at that group a little bit bigger. So in those patients, again, the indications are the same. You see if they have a guideline indication for treating the AS. Is it severe AS? Are they symptomatic, or do they have a depressed ejection fraction? You then assess their valve and vascular anatomy, and you assess if they're suitable for TAVI. And to me, this is a paradigm shift, because before you're assessing them for surgery, you're actually assessing the patient for TAVI first, right? And then you look at their age and life expectancy. So if they're less than 65, the guidelines suggest surgical AVR. If they're 65 or 80, okay, the guidelines actually give a class 1 indication for both surgical AVR and TAVI. And so it's really the heart team discussion that becomes extremely important as to what we should do, right? Is the patient, and also the other thing that's really important here is the fine print. So it says TF TAVI. So TAVI is only considered equivalent to surgical AVR in this group if it can be performed via the transfemoral route. Otherwise, it shouldn't. And then in patients older than 80, it gives actually a higher indication to TAVI rather than surgical AVR. So TAVI gets a class 1 indication and surgical AVR gets a class 2A indication. And I think these are, some people consider these guidelines extremely aggressive, others consider them extremely progressive. I'll stop here just for a second before moving on to mitral and tricuspid very briefly to see if there are any questions from anybody. Juan, you have any comments?
No, I think they are reasonable and reflect all the data we have right now. Obviously takes into consideration the historical data with a surgical replacement, not necessarily the data about surgical replacement, but is a very, very reasonable, and as you're saying, a simplified approach.
All right. And the guidelines also, I think, for the first time, try and help us decide between these two groups. So I see, just before I move on, from Jesse, that he asks, what are the guidelines? Is there a guideline for SAVR less than 65 based mostly on bicuspid? So let's just talk about bicuspid. And I think that's a great question. That's a great question, Jesse. And so what the guidelines have done is they actually provide us with some, why is this not showing? Okay, there we go. The guidelines provide us with some help in trying to decide between surgical AVR and TAVI, right? So we talked about age. So, the younger the patient, the longer their life expectancy, the more likely that favors AV surgical. If they have bicuspid anatomy, subaortic or left ventricular outflow tract calcification, rheumatic disease, or smaller large aortic annulus, that favors surgical aortic valve replacement. Whereas if it's tricuspid, it favors TAVI. So when it comes to bicuspid, Jesse, the feeling still is today that patients with bicuspid aortic stenosis should undergo surgery, and surgery is a class 1 indication, especially if they're young. In patients who are older or high risk, even in, TAVI has been performed with really good outcomes. And certainly in our practice, in a patient who's, say, over 70 and low risk, who wants TAVI over surgical AVR, and they have favorable anatomy, bicuspid anatomy, we will consider it. But it's still in the guidelines, would push you more towards surgical AVR rather than TAVI. Then other things to think about to make this decision is, whether the patient needs a mechanical or bioprosthetic valve, right? I think if it's a bioprosthetic valve that the patient does not want to take anticoagulation and they're 66 years old, and they're going to get a bioprosthetic valve, we will also offer them often TAVI in that case. And then there are things, sometimes we don't always think about, patient prosthesis mismatch. So here again, in a patient with a small annulus, you need to know your surgical center and your surgeons and how likely they are to perform a root enlargement in these kind of patients. Because if they are, then, great, surgical AVR with root enlargement may be more appropriate in someone with a small annulus. But if you work in a center where maybe the surgeons are reluctant to do root enlargements, then you may want to do a TAVI because you will end up giving the patient a larger valve area, and less patient prosthesis mismatch. Then other things that matter, concurrent cardiac conditions, such as other valvular disease, if they have aortic dilatation, if they have severe 3-vessel coronary artery disease with a high Syntax score, it'll push you towards surgery. Things that will push you towards TAVI are comorbidities, a porcelain aorta will push you towards TAVI, a patient who's more frail. And then there are a few other things I won't really go into the details of. So that's kind of for aortic, what the American guidelines say. So I'm going to very briefly then talk about mitral. And I'm really just trying to highlight the things that are different in these guidelines compared to what was in the past, and maybe what you'll see when Bernard joins shortly and talks about the ESC guidelines. So here we also saw a big change, and this is different. And the change in the guidelines for mitral were really in secondary MR. For primary MR, the guidelines did not change. They still recommend surgery in patients who are low and intermediate risk, and they recommend mitral clip, which is the only really approved therapy in the United States, for patients with high or prohibitive risk with primary MR. Okay, with secondary MR, I think the guidelines really took the COAPT data and adopted the COAPT data. So what they say is, you have a patient with functional or secondary MR, you then have to have the patient on GDMT, which is supervised, and this is interesting, by a heart failure specialist. So this does not necessarily have to be someone who only does heart failure, but it has to be someone who has a lot of experience in heart failure and can make sure that the patient is on optimized medical therapy. Once they've been optimized on GDMT, you then evaluate their MR. If their MR is still severe, okay, and they've got a regurgitant volume, so defined as regurgitant volume more than 60, regurgitant fraction more than 50, or an ERO greater than 0.4, you then divide them into whether their ejection fraction is greater than 50 or less than 50. So greater than 50, and they have severe persistent symptoms on optimal GDMT and AF treatment, they say mitral valve surgery has a class 2B indication, okay? If the ejection fraction's less than 50, okay, and they have persistent symptoms, and they have mitral anatomy that's favorable for mitral clipping, which is defined as ejection fraction above 20, so 20 to 50, and end systolic diameter less than 70, and a pulmonary artery systolic pressure less than 70, then they give edge-to-edge repair, which is essentially mitral clip, and Pascal in the future, a class 2A indication. So this is the first time in the guidelines, and any guidelines in the world, where any therapy, any intervention, whether it's surgery or it's transcatheter, gets an indication stronger than 2A. I mean, stronger than 2B, gets a 2A indication. If you look, mitral valve surgery, actually in this group of patients, has a 2B indication, and so a lower indication than mitral clip, and should only be thought of in a patient who does not have favorable anatomy for mitral clip, okay, and has severe symptoms. Where surgery does get a 2A indication is the patient with severe MR who's undergoing CABG. Okay, there is randomized data showing there that if you're undergoing CABG with severe MR, mitral valve repair in conjunction with CABG results in better outcomes. So this is how the class 2A indication reads. It says, in patients with chronic severe secondary MR related to LV systolic dysfunction, so ejection fraction less than 50%, who have persistent symptoms, so NYHA class 2, 3, or 4, while on GDM, optimal GDMT for heart failure, TEER, transcatheter edge-to-edge repair, is reasonable in patients with appropriate anatomy as defined on TEE and with an ejection fraction 20 to 50 and systolic diameter less than 70 and a pulmonary artery systolic pressure less than 70. So that's what the guidelines says. And I thought it was amazing how the US guidelines have actually really adopted COAPT, because this is really based on COAPT, right? And applied COAPT into the guidelines. I just wonder, now that we have this, what it's going to take for edge-to-edge repair to become a class 1 therapy. Any thoughts? Another randomized study, I guess.
That's going to be tough, yeah.
Yeah, another randomized study. Okay, great. So I'll do one last one, and I'm hoping Bernard joins us by then. He said he should be here by now. So that was mitral. I'll do then one more, which is just briefly mention tricuspid. Okay. And what the AHA guidelines say about ACC AHA guidelines say about tricuspid. So the interesting thing, I'll make it easy, is in the ACC guidelines, there's absolutely no mention of any transcatheter therapies for tricuspid repair or replacement done by the transcatheter route. Okay, and that's because there are 3 pivotal studies underway in the United States to look at whether these therapies are better than medical therapy. So if you look at TR, the current guidelines divided into severe TR, progressive TR, okay? And if you have progressive TR and you're undergoing left-sided valve surgery and you have annular dilatation greater than 4 or prior right-sided heart failure, then tricuspid valve surgery is recommended. So you should treat the tricuspid at the time of the patient's undergoing left-sided surgery, right? But if you look at class 1 indication, right, there's only one class 1 indication for tricuspid, and it says in patients with severe TR undergoing left-sided surgery, tricuspid valve surgery is recommended. So that's the only class 1 indication, right? The rest are all class 2 indications. And when we look at the class 2 indications, they're really based on the fact that you have to have severe TR and you have to have right-sided heart failure. If you then, the cause is primary, you have a class 2A indication. If the cause is secondary and you're poorly responsive to GDMT and you have annular dilatation without an increase in pulmonary artery pressure or left-sided disease, you have a class 2 indication. If you've had prior left-sided surgery, okay, and now you have isolated TR, you actually only have a class 2B indication. Interestingly, this is probably the largest group of patients that I see are these patients who previously had left-sided surgery and now have severe TR. So, the guidelines for TR are still pretty restrictive when it comes to tricuspid regurgitation. There's really only one class 1 indication, and that's in patients who are actually already undergoing left-sided surgery. But treating isolated tricuspid valve surgery, whether repair or replacement, actually has either class 2A or class 2B indication. So I'm going to stop there for a second, and I'm just going to check if Dr. Prendergast is ready to join us. If not, then we may just have to schedule him for another time, because he really is an amazing speaker, and I don't want you guys to miss out on him. But that's kind of about all I can, at short notice, keep you entertained with and discuss with you. But let's see if there are any questions. So Juan, here's a question. I've been talking a lot. From Luis. Luis asks, what is your opinion about the cutoff of 65 years in the US guidelines, especially when, if you look at the low-risk TAVR study, the average age was actually 72 years.
I think age is actually based more on the perceived longevity of the prosthesis more than the data actually based on the trials, right? Because that's what it all comes down to in these devices. There is historical data from surgery, that they talk about longevity of 20 years, survival or functionality, which is debatable and we can actually talk about. But I think this is kind of like what I think the writers are looking at. I mean, you put a device in, whatever it is, you want to make sure that it stays in for the rest of the patient's life. And right now, because we have limited durability data in terms of longevity of the implantable device in TAVR, is difficult to actually, have the discussion yet. All right. I think that once we start getting, 10, 15, 20 years data, and we know the longevity of the implant, I think that actually discussion is going to be easier to have. So I really think right now it's very smart that it was divided by age groups, but I think the discussion is more about the device longevity and functionality rather than functional status of the patient. Because if it comes down to functional status of the patient, a less invasive therapy will be actually more desirable than a surgical approach.
Right. So I completely agree with you, Luis. Let me just respond to Dr. Prendergast here. It is, there's a lot of discussion about where this number of 65 came from, because the low risk studies, like you said, had 72 years. So I don't want to take away from Dr. Prendergast's presentation, but you'll see the European guidelines were more conservative and stuck a little bit more to the clinical data about where the average age was. However, if you look at the age range of patients included in the low risk studies, there were many patients who were less than 72 years of age or less than 70 years of age. That's kind of where you come with the average, right? If it's 72, your bell curve is on either side of that. So there were a significant amount of patients below 70, and above 65 that were included. But I think what you say is right. A lot of that cutoff of 65, why not 60 then, if you're going to go lower, right, is got to do with what we think the longevity of transcatheter
plus 20 is 85. I mean, I really think that that's the way that, the debate, I really think that's why I believe durability of the implant, and that's why there is so much work on leaflet technologies, is going to determine the preferred, approach for these patients, because that's what is going to determine the final interventional surgical approach.
Right.
Or hybrid approach.
So I just want to see if there are any other questions. So there's a question, great question from Nadesh. How about end-stage renal disease patients who have a high rate of, you say TAVI degeneration? I'm going to say biological valve degeneration-ish. So, our experience has been that in patients with end-stage renal disease, their rate of degeneration is accelerated, and it's accelerated for all biological valves, whether that's a surgical valve or a transcatheter valve. It's still extremely variable. We don't know what the exact rate of degeneration is. I think you're right. I've seen, TAVI valves degenerate after 2 years in someone who's on dialysis. But I've also seen that with surgical valves. I think this is still a group of patients that we do not have a great solution for. So I think it looks like Dr. Prendergast is still struggling. He's still busy with a case. So I'm going to say we have an early session today, and we'll try and get Dr. Prendergast next week, since we have an opening next week. So I'm sorry you had to put up with me, but next week we'll have a great speaker for you with Bernard Prendergast, and it will be maybe a great way then to compare these guidelines, the American guidelines with the European guidelines, and kind of try and understand why there've been these differences and why there are these differences across between Europe and the United States. So thank you everybody for joining. I'm sorry we couldn't get you Dr. Prendergast today, but it's the reality of Zoom and fitting into everybody's busy schedules. We'll see you next week. Take care now. Bye-bye.